Welcome to this continuing education activity titled Navigating Challenges with PD-L1 Combined Positive Score. My name is Joe Kim, and I will be the moderator for today's panel discussion. During this panel discussion, we will describe how PD-L1 expression is determined using combined positive score. We will also outline some of the challenges that pathologists face when using CPS or combined positive score, and we will discuss ways to achieve accurate assessment of PD-L1 protein expression when using combined positive score. Now I'd like to ask each panelist to please introduce yourself.
Hi, everyone. I'm Wei, currently at University of Kansas Medical Center. I actually just moved here in April. I used to work at University of Wisconsin at Madison. Again, I'm currently the medical director of molecular pathology in solid tumors. I do GI, surgical pathology, and molecular pathology at KU.
Thank you. And Dr. Schroff.
Hi, everyone. I am Sudhi Shroff. I am a practicing GI liver pancreas pathologist. I've been doing subspecialty sign-out in GI liver pancreas pathology for about 10, 12 years now. And currently I'm at the Massachusetts General Hospital where I do GI liver pancreas sign-out, and I also head the frozen section intraoperative service. Prior to that, I wasn't attending at the University of Pennsylvania till about 2018, where I also did only GI liver pancreas. And then prior to that, I did a couple fellowships in surgical and GI pathology at the University of Texas, MD Anderson Cancer Center.
Hello, I'm Lamis Saeed. I'm the breast pathology fellow at Moffitt Cancer Center, where I also did an oncologic molecular pathology fellowship there as well. And I'm happy to join you in this panel today.
So let's start by talking about combined positive score, or CPS. What exactly is CPS and how is it defined?
For CPS, we're talking about combined positive score, which we including the stained tumor cells and lymphocytes and macrophages, and divided by the total viable tumor cells. So the final score may over 100 because we counted lymphocytes and macrophages.
Thank you, Dr. Zhang. So combined positive score, or CPS, is challenging for a number of different reasons. And we've got a list of these reasons listed here on the slide. To get us started, Dr. Schroff, can you explain to us from the work that you do and the kinds of tumors that you're diagnosing, what makes CPS so time-consuming and challenging?
There's a few different factors that certainly, I think, in my opinion, make CPS challenging. The role of CPS, the score that is actually going to be utilizable for the oncologist, is changing. The cutoffs are changing. For certain cancers, the cutoff is a CPS score of 1. For certain cancers, especially in combination with chemotherapy, the cutoffs are 5. For certain other cancers, the cutoffs are 10. From a pathologist perspective, given that the field is rapidly evolving, it is uncertain to know which cutoff is going to be utilized by the oncologist in a specific kind of a setting. In terms of actual histologic scoring, when you are close to the cutoffs, one needs to be absolutely careful about how the slides are scored. And when there is a lot of background staining or a lot of ulceration, when there is lymphocytes that are picking up the stain, but they're not adjacent to tumor cells, those kind of cases, the scoring becomes especially challenging because it takes more time to parse out which is actual staining that should be recorded for the purposes of the actual score versus which should not be.
Thank you so much, Dr. Schroff. Dr. Saeed, in your training as a fellow, what were some of the issues that you ran into when it came to CPS scoring?
As a fellowship trainee, there were a lot of technical issues that I encountered as well. For example, there's always the issue of a limited biopsy material, or the need for performing additional IHC before the PD-L1, which might exhaust the block itself, and that also affects the quality and the quantity that we have to determine the CPS scoring. So Some of the solutions for that might be if the oncologist would annotate head on that this biopsy material is meant for that reason, to perform PD-L1 or to prioritize it over other IHCs. Another thing would be if we save the block with the most tissue for that PD-L1 IHC.
Thank you very much, Dr. Saeed. Dr. Zhang, in your role now, as well as in your former role, what were some of the challenges when it came to CPS?
Reading interpretations, I totally agree with Dr. Stroff. It's pretty challenging for the GI pathologist, I would say. The necrosis, as she mentioned, necrosis and age effect fixations. So I think it's getting better now, the fixation, because we also have a cutoff time for the GI biopsies for fixation, just similar as breast biopsy. So 6 to 72 hours that you don't go too short or too long for fixations. I would say in reality, in practice, the most challenging part for me is really the stroma cells in the tumor. And she mentioned the lymphocytes and mixed neutrophils also pick up the staining too. So those neutrophils and the stroma cells, extremely challenging for me to how to give a definitive score. And the other thing is, as she mentioned, there are a lot of trials going on, whether your cutoffs 1 and 5 or 10 make very big difference. Unfortunately, we're just doing estimations. We're not really using any software AI to give a definitive score. So that will make a challenge, whether it's 5 or 10. That's a lot of struggle there.
So I would say that when it comes to cases where I feel that we are going to be approaching a cutoff, say if we are at the boundary of between 1, greater than 1 or less than 1, but just around that number, then I will actually sit down and do an actual count. When I'm at the cusp of 5 or less than 5, I will actually sit down and do an actual cutoff. If I feel I'm broadly in the range of a few hundreds, the CPS score is going to be in the hundreds, then I think it's fair to do an estimation, because the patient is going to qualify for therapy regardless of whether the score is 50, 500, or 100. So for those, I feel it's fair game to do an estimation. But I will say that when one is at a score that is close to a cutoff point, the time restrictions that that you kind of alluded to earlier, I would say sometimes it takes me up to 45 minutes even to do a single slide for CPS counting. One of the other issues I think that we did not touch upon was the fact that I think there is some tumor heterogeneity within a variety of different tumors. We're supposed to be doing CPS scores for stage 4 tumors predominantly. But when the patient has achieved stage 4, the site at which a CPS score is performed can be either the primary site or the metastasis. And in my experience, sometimes when a staining is done at the primary site versus the metastasis, the scoring can be different between the two, and that might change whether the patient qualifies or not for therapy using a checkpoint inhibitor. So I feel that is also an additional challenge that is actually not discussed as much.
So we do have the same issues, metastatic site or the primary site, but in our experience is the metastatic site is cleaner because less inflammatory infiltrates in the metastatic tumor. So we actually prefer to do them on the metastatic site if there's a mets according to, related to the same specimen. And Dr. Stroff, I want to ask you a question. So when you really count the cells, do you count under the scope or are you going to really print them out?
I actually do count using a pen and paper, using the screen, or I'll take a picture on my screen and actually do a physical count. But I don't use any artificial intelligence or an algorithm to do that. It's a manual count. Since there is no, the cutoff is only presence of 100 tumor cells or not, which is pretty low threshold, I feel. I try to go at least 400 or 500 cells at least in total, whether it's tumor cells, lymphocytes, combination thereof. There has to be at least that many cells for me to be able to, I feel, give an adequate score for CPS.
Being trained specifically for the breast pathology, I've seen all kinds of styles and techniques of counting for the CPS, specifically for those cases that are approaching the cutoff. However, manual morphometry, and that's manual counting, is the standard. And a lot of pathologists would even use a manual cell counter for that regard as one of the techniques. Another one would be, like Dr. Schroff mentioned, printing out the picture, the field picture, or annotating it using the computer software. However, no AI is involved. It's all manual morphometry. And as well as validating that with a second pathologist opinion or showing it during consensus meetings. And that would be more of an estimation technique based on the actual count.
Counting, there's no way you can show a second one count together.
Exactly.
But estimations, you can say, I'm at 5%. Do you agree? It's we have a panel. We do the regular consensus meeting for cancer, for anything. So those will bring to the consensus meeting as well. So that's what we do. Counting, I don't think is possible. I completely agree with that. And again, counting also depends on which picture you've taken, the hot spot that you like, just heterogeneity, right? So if you already take that spot, you count it. How can I disagree? There's no way I can disagree with that because you have your paper, you have the count. Yeah, no, that's what I think.
I've also noticed there's a heterogeneity within our group in terms of reporting the CPS scoring. Some people give a very detailed score where they'll actually say how many lymphocytes are positive, how many tumor cells are positive, how many total tumor cells were present within the areas that were counted, while others will just say CPS score greater than 1. And at least as far as our oncologists are concerned, we've never received a pushback on either of the two. However, I feel that going down the road, if more and more cutoffs do appear, I worry that knowing that just a CPS score of greater than 1 is not going to be sufficient. I feel that is also a challenge with regard to CPS scoring, is that there's heterogeneity in reporting the scores across various institutions and various tumor types.
So 1, 5, 10 as the key is the key point now. You have to give a definition for that so that they can enroll in different trials based on its nivo or its pembro at the moment. And I totally understand from a pathology perspective, where even though sometimes I can't, I say 5, but whether it's really 5 or 8, that's very, difficult. And again, we don't report anything is whether it's lymphocytes or macrophages, just give a number, but we do say more than 5 or more than 10. More than 1 is definitely not enough for now. That's for sure. You have to give a definitive number, especially between, regarding 5 and 10. I'm not sure whether the number will change in the future or not. On the other hand, I don't know where it's reporting the lymphocytes, macrophages, but I honestly not very confident to see based on the immunostain to be sure this is lymphocyte. These are macrophages, and these are stroma cells. I'm excluding. That's the true challenge for me.
So this is an example of a triple negative breast cancer, and you can appreciate from the H&E the higher grade of this tumor. And when PD-L1 IHC was done, you can see that the tumor cells are staining, and there is membranous staining. However, even though it has some good intensity to it, intensity does not matter in this regard, and it wasn't enough to reach the 10 cutoff for the CPS score in this case. The next example is a metastatic triple negative breast cancer into the liver, and this is a liver biopsy that you can see on the H&E. And the PD-L1 staining, although it is more faint or more granular membranous staining than the previous example, however, it has more staining, more cells, and that contributed to a CPS score of more than 10. So I wanted to show these two examples of the triple negative breast cancer and how heterogeneous or how morphology can be different at the same time as the intensity, which in this case does not factor in.
So this is the metastatic tumor. You can see that the tumor cells, metastatic side, especially in these situations, you can tell that not a lot of inflammatory cell infiltrates, majority of tumors, and the staining is pretty strong. These are membranous. And this one we call 20%. Although, again, I think 1, 5, 10 is the one that we want to know now. And I want to show that slide as well, because probably, again, breast has different cutoff. That's why, you probably don't need the 5 informations. But for upper GIs, they have, based on the NCCN guideline, this is the most updated one, that they actually prefer, they do HER2 first. If HER2 overexpressed, they don't have, they probably going to put on the HER2 trials first. And then for the HER2 negative ones, they do based on CPS score, give different category, and treatments can be slightly different. This is a negative one. It's very easy to tell that these are just, you can see this is from this area, this is the stroma, and this is, like little, not mucinous, but kind of amorphous area, but also pick up some non-specific stainings. So these are the ones we call negative, even less 1%. And this is actually from my current, I just had this case probably 2 weeks ago. And I took only focal pictures. Actually, majority of the tumors are down to the deeper of the mucosa. Those are completely negative. And then these area has necrosis and also has plasma cells, lymphocyte neutrophils. They pick up a lot of staining. Eventually we call it negative, but it's very hard if you don't compare very carefully and look at everything, it'll pick up stainings. The necrosis, stroma cells, neutrophil. I don't have a lot of stroma cells for this situation, but it happens in a lot of cases as well.
Within the GI tract and the gastric and gastroesophageal junction adenocarcinomas that we are often required to do the CPS scoring for, I think the signet ring cell morphology, the poorly differentiated, poorly cohesive carcinomas that are metastatic to peritoneum, oftentimes we get those biopsies or requests on those biopsies to do CPS scoring. And when they're metastatic to the peritoneum, peritoneal cavity, I find those cases to be extremely challenging because the tumor cells become very small and squiggly and can be very difficult to identify in that kind of a background. So I find those cases especially more challenging compared to those that are metastatic to other solid organs or anything like that.
I want to add on that, the poorly cohesive ones, and from my experience is signet cells may be a little better than the non-signet cell type. The non-signet cell type poorly cohesive ones, they look like very similar to lymphocytes. So those are the really difficult ones for me to be sure there are tumor cells or not. But on the other hand, you count lymphocytes as well. So that part is solved.
Dr. Saeed, any comments that you'd like to make?
So with the specificity in the CPS scoring for the breast is that we're counting the mononuclear inflammatory cells, and that's the macrophages as well as the lymphocytes. It's helpful to keep in mind that the multinucleated ones do not contribute. Just like the example that was shown where the neutrophils pick up that stain, however, they do not contribute towards the CPS score. So that's a very good point to keep in mind when counting the CPS score. Because it can have a focus of inflammatory cells, and that we always have in mind that these count along with the tumor cells in CPS. However, they're only for the mononuclear ones, not the multinuclear.
So what are some of the practical suggestions or key takeaways that you would want to emphasize as we get ready to wrap up? What should pathologists, laboratory professionals, what should they keep in mind as they think about the challenges around CPS scoring?
I think, as you said, we all discussed, it's very challenging to do CPS score is a lot of time. But I think most of us, probably most pathologists has done the training. There is a free training on the DACO website. I learned a lot. I think that's very helpful to do a little training. I hope there are more website or companies can do these kind of trainings more than before, and I do like the counting part, although I'm not, a lot of time I'm estimate the percentage, I have to say, based on the time limitations. And counting part, I think I do like that, and how to train us to pick up the best area and what's the best way to count them, or whether we can use some software to help. We do have the software here to help the breast markers. We do use them for the breast marker Ki67. I hope they can insert some algorithm for CPS scores to help us at least has the estimations, and then we can confirm based on our image taking.
Thank you. Dr. Saeed, how about from your perspective?
Absolutely. So I totally agree with that. And the fact that a lot of the pathologists right now being subspecialized, like you mentioned, it's very, very important to keep up with the training and keep up with the new guidelines, as well as any activities like this CME activity that we're participating in. All these are helpful resources. And worth mentioning that I just recently attended a breast pathology conference where there were panelists of breast pathologists from across the country, and they were discussing hot topics in breast pathology. And one of them, for sure, PD-L1 was top high on the list. And you can see that across the country, it is a challenging area where a lot of pathologists have been approaching it differently. Like some institutions rely on send-outs, some institutions rely on a sole pathologist to be the expert in that field. So all the PD-L1 cases go to that pathologist. And some pathologists still have the general sign-out, and they do see all kinds of cases, and that's where that continued education is important to keep up with all those new changes.
Thank you, Dr. Saeed. Dr. Shroff?
So I think from the perspective of learning or teaching how to do CPS scoring, I think the companion diagnostic that is there from DACO is a good resource, but I am not certain that it is available or everybody who is in the field is aware of that specific document of how to score. I know personally that I have forwarded the document to some of my trainees or colleagues who have been like kind of a little bit confused how to do the scoring. So I think more awareness would certainly help. More examples from practical perspective would help. In a busy practice such as mine, perhaps a little bit more discussion on a regular basis, every new academic year or something like that, to kind of bring new trainees on board as to how the staining should be assessed and what are the challenges with it. I don't think all of, especially the areas of ulceration that cells around that should not be scored. Again, that is not a very well-known fact, especially among newer practicing pathologists or trainees. I think the tediousness, the amount of time that it takes to score, if there's a way that can be better delineated, because well, these cutoffs do exist of 1, 5, 10 for various different cancers. And then standardization of reporting would also be, for me, an important aspect that I think would be worth mentioning, because the cutoffs are ever evolving. When about 5 years ago, checkpoint inhibitor therapy was being used for G-junction gastric adenocarcinomas, all that was sufficient to know was there was a cutoff of 1. Now we have 3 cutoffs of significance. I can certainly see that down the road, there's going to be more cutoffs that might be of value. So just reporting a cutoff of greater than 5, greater than 10 may not be sufficient for a patient down the road. And then could there be additional testing that might be requested down the road on the same tumor types for which PD-L1 was effective? And those kind of things, those kind of questions, it would be important to have more information, more conferences addressing these issues. I think down the road would be certainly helpful. I think this is quite a challenging and evolving area, which is quite significant in terms of how patients are triaged down the road. And from a pathologist perspective, we are quite central to patient care, especially with regards to this one. I can see more and more biomarkers being used, and having consistent or good guidelines for scoring would certainly be very, very helpful down the road.
Being at a cancer center with 8 breast pathologists, where I'm the fellow for all 8 breast pathologists, I can get to see those cases coming in for the PD-L1 testing. And within the triple negative breast cancer, which is, let's say, the less common than the ER positive, some of those are requested by the oncologist to perform PD-L1 testing. So it's by request, which even contributes to less volume. However, like we discussed, those cases approaching the cutoff specifically are being shown between the breast pathologists to reach the correct CPS score in that case, whether it's counting or estimation. But consensus is a major part of that, determining the right CPS score.
Yeah, I think that maybe a year or 2 years ago, I heard big panel discussion in the oncology meeting. They're also saying, like, even big institutions, they also sit together to get consensus for these kind of scoring system. It's just scoring as a pathology together. It's just very hard, and they wanna, all of us wanna give an accurate score to help the patient. I want to add one thing, because the guidelines changing all the time. So whether the PD-L1 IHC supposed to be reflex testing, or because already first line, no need for reflex testing. So those, if we can update these reflex testing and communicate with oncology more closely, that'll be very helpful. So you don't have to perform this for every single patient, which are not used clinically. Then your time is wisely used. You know what I'm saying? Only when it's needed, and we'll perform it, and we'll try to give an accurate score to help the clinical decision making.
Thank you to the panelists, and thanks again for joining us for this continuing education activity.